Hello everyone. We are going to continue today by talking about urticaria, otherwise known as hives. And I want us to know that these lesions usually develop due to a type 1 hypersensitivity response, right? And how do they appear? They appear as sharply demarcated. So we have it here, sharply demarcated edematous plaques with surrounding areas of erythema, just like we have here. They are sharply, well demarcated edematous plaque with surrounding area of erythema. And we have to talk about the fact that they are transient. So it occurs in two forms, the acute and the chronic form. The commoner one is the acute form, and it disappears within 24 hours. It doesn't last for more than 24 hours. So once you see these eruptions, appearing and disappearing after 24 hours or before 24 hours, you know that this is likely to be the urticaria lesions. You can have the chronic form of this urticaria that lasts for more than 6 weeks. So if you have something that appears like this, well demarcated edematous plaque with surrounding area of erythema lasting for more than 6 weeks, that is a chronic urticaria. We have to talk about the pathophysiology, how it happens, because it can be tested in questions. We have talked about the fact that it is a type 1 hypersensitivity response. So that means that definitely this is IgE mediated, right? It is IgE mediated. It is IgE mediated. So, and we know that IgE cross-links on the mast cells and the basophils, causing degranulation of the mast cells, the basophils, making them release the histamine majorly, as well as the prostaglandin. So, and this is going to lead to vasodilation that is going to bring about extravasation of fluid into the dermis. So the vasodilation will affect the dermal capillaries, causing fluid extravasations into the dermal tissues. And that brings about the urticaria. Don't forget, it is the dermis, that is affected majorly. The dermis. So, and you are going to have these lesions and the symptoms of the pruritus, the pain, the erythema, from the histamine. And just like we have said, they are known as the hives, or you call them the wheels, right? Because they are erythematous. Sometimes they can be whitish, right? Papules, or most commonly plaques, because most commonly you see them very big, as plaques. Sometimes you can have small lesions, as papules, or most of the time you see them very big like this, as plaques, representing dermal edema, just like we have talked about. And the lesions are usually widespread, right? It can occur from the head down to the toe. They are widespread. So they represent type 1 hypersensitivity response, especially in severe allergic reactions, right? So maybe the person used a particular medication, or the person, got stung by a bee, or the person um, was exposed to a certain virus, right? It could be viral, it could be, wasps, bee sting, it could be due to drugs, right? It could be due to food, you know, and the individual is going to have the constellation of these lesions. Sometimes they can have some extracutaneous manifestation depending on the severity, right? And they are going to have some features of subcutaneous tissue swelling in very severe cases. So, and all these are still due to the interplay of the histamine and the prostaglandin, causing vasodilation and fluid release into the tissue. So it can affect the subcutaneous tissue of the face, in which you are going to see periorbital swelling, just like this individual here. This individual having periorbital swelling. You can see tongue swelling. This guy doesn't have tongue swelling, but sometimes they can have tongue swelling, right? They can have airway swelling. The histamine can affect the bronchial airways, causing bronchoconstriction, and they are going to have features, similar to asthma. The histamine can exert some, peristaltic, effect on the GIT, causing cramps, causing diarrhea, right? Sometimes you can have joint problems, joint swelling, and even fever, because fever is part of the cardinal signs of inflammation. So the fever, the airway features, the subcutaneous swelling in the face, the tongue, the face, should raise your suspicion for angioedema. And angioedema can be life threatening because if they have occlusion of the airway, they might find it very difficult to breathe. So you might need to quickly, take over that airway to keep them alive. Um, so just like I was said, the acute urticaria usually occurs in response to so many triggers like, food. It could be due to food, it could be due to drug that the individual is exposed to, and we are going to talk more about this by the time we are talking about drug eruption. Some viruses can trigger this, insect bite, you know, bee sting, and the likes, and even physical stimulus like exposure to cold, exposure to sun, exposure to high temperature, very high temperature or heat can also trigger this. And don't forget the chronic urticaria can occur when you have development of the this rash, this sharply demarcated edematous plaques or papules for more than 6 weeks. That is chronic urticaria and it is usually idiopathic. So it doesn't usually occur secondary to the food or drug or virus because this one are usually acute in onset. But for the situation of the chronic ones, you don't know the cause most of the time. So how do you make your diagnosis? You can make your diagnosis by doing your exam findings and obtaining your history. Get a history of the person has taken a particular food, drug, had a bite from an insect or a bee sting, right? You check the skin lesions. They are looking like this exactly. You are dealing with urticaria. Sometimes you can do what you call a dermatographism. So what you are trying to do here is just to apply pressure to the skin. You stroke the skin and you see that these wheels of this urticaria rash newly appears. So by the time you are, stroking the skin, you notice that you are forming wheels in the direction where you are stroking, right? So that is what you call positive dermatographism. So it's one of the peculiarities of urticaria. If you are still in doubt, you can do some lab work because part of the um, um, mediators or the inflammatory mediators that is released, from the mast cells and the basophils in your type 1 hypersensitivity is tryptase, just like I mentioned yesterday or the last video that I watched. Um, Histamine, prostaglandin, leukotriene, tryptase is one of them. So tryptase can be measured. You obtain a serum measurement of tryptase to confirm or clinch the diagnosis, right? In situations where it's very difficult for you to, establish diagnosis. Sometimes it might be difficult to determine the cause of the urticaria, right? Sometimes, but these are the common ones: the food, the drug, the virus, and the insect bites, and sometimes physical stimulus like cold exposure, heat, and sun. So how do you treat? So we have to pay attention to this treatment. We should not get carried away, and because we have to be very clinical. Look at how the patient is presenting. This patient is just presenting with the urticaria rash. No, nothing like hypotension, nothing like angioedema. Just normal rash, puritic rash. That is all. Just give your systemic antihistamine and you move, right? But if you see that the patient is already becoming hypotensive, having airway obstruction from angioedema, you know, you have to do more, right? And the most important stuff you want to do there is to give your intramuscular epinephrine because that individual is already progressing towards anaphylactic shock, right? And intramuscular epinephrine is the best to give first, not even IV epinephrine, but intramuscular. So you can give a limited dose, with your intramuscular, and you limit the side effect of epinephrine. So don't choose intravenous, choose intramuscular epinephrine. You can add your antihistamine with it because for the fact that patient is hypotensive, you have to administer intravenous fluids. And if there's a need to take care of the airway, provide airway support. Very, very important. So once you see that the patient is already going towards anaphylactic shock, IM epinephrine is the first thing. If the patient doesn't have anaphylactic shock, just give your systemic antihistamine and you will be okay. So moving on to drug eruption. So drug eruption is just manifestations which could be dermatological, dermatological manifestation that happen when you administer a drug to a particular patient, right? And this dermatological manifestation, ranges within like a spectrum. So most of the time they have this mobiliform rash presentation. So when you say mobiliform, what you are trying to say is that a rash that resembles measles presentation, measles-like distribution. So that means you are talking about somebody that has a fine, just like this individual here, a fine, though this image is not very clear, but you are going to see fine maculopapular rash, fine maculopapular rash that has a centrifugal distribution. So that means that the rash is going to be starting either from maybe the head, neck, or the trunk, and it's going to be moving outwards, right, to the extremities. That is classic for measles, right? And that is what you call the mobiliform rash. So this is a commonest pattern. This is a commonest rash pattern in individuals with drug eruption. It can span from, normal mobiliform rash or erythematous rash to life-threatening presentations like toxic epidermal necrolysis. So what we are saying here is that some individuals can just have normal maculopapular rash fine, while some individuals can have, rash affecting the skin with subsequent necrosis and sloughing off of the epidermis. So when you have splitting or shedding off of the epidermis, right, that is what we call the toxic epidermal necrolysis. So that's an extreme form of drug eruption, right? So you have to have a very high suspicion of cutaneous drug reaction in the patient who are hospitalized and they develop rash afterwards. You know, the timing or the onset of the evolution of rash tells you, if you are dealing with a drug eruption or not, right? And we have to know that drug can cause all the four types of hypersensitivity reaction. All the four types. Please don't be surprised. Type 1, type 2, type 3, type 4 can come from drugs. For example, in the type 1, you administer a drug to a patient. Maybe you give the patient penicillin or cephalosporin, and subsequently within minutes to hours, the patient develops the urticaria rash, right? Start having erythematous, you know, edematous plaque within the body, right? Which is pruritic. Start having facial swelling. You think about allergic, reaction, a drug-induced urticaria rash. So that is a type 1 hypersensitivity already. Sometimes you can administer drug to some individuals and they can develop drug-induced thrombocytopenia, right? That is a type 2 hypersensitivity reaction. They just develop antibodies, autoantibodies that start, destroying those self-platelets. That is a type 2 hypersensitivity. So drug-induced thrombocytopenia is a very good example of type 2 hypersensitivity. And these people can present with petechial rash, right? Drug-induced hemolytic anemia is another good example. For the type 3, you can look at serum sickness, right? Serum-like sickness. Serum-like sickness, you administer medication and subsequently you see the individual they can have wide range of rash. It could be mobiliform, it could be papular, it could be pustular, it could take any form for the case of the serum-like sickness. And of course, you are going to be getting some additional features like the individual having fever, having arthralgia, having maybe some renal manifestation, hematuria, they could have, so many things, lymphadenopathy, you think about the serum-like sickness. That is a type 3 hypersensitivity reaction to drug use. Then the last one, which is the fourth, is them having, the Stevens-Johnson syndrome and the toxic epidermal necrolysis, or even the DRESS syndrome, which we are going to talk about shortly. So that's a type 4, and that one is cell-mediated, right? So don't forget, when you see mobiliform rash within trunk spreading to the extremities, think about drug reaction, right? And we have a key fact here. Patients with drug reactions usually have peripheral eosinophilia, which is very important. They usually have high eosinophil count. And even if you do your biopsy of the rash, you are going to see a very high amount of eosinophils within the lesions. Yeah, it's classic. People with Steven Johnson syndrome, people with Dress syndrome, people with the type 1, they usually have elevated eosinophils, you know, in their blood as well as the tissue biopsy. So, presence of eosinophilia or high eosinophil count when you do your biopsy, it's also suggestive of drug eruption. So, moving on to the history, right? So, for the allergic eruptions, that is like drug-induced urticaria, we have said it that the onset of the lesions is going to be within minutes to hours after drug administration, right? But for the non-anaphylactic eruptions, they usually occur within 1 to 2 weeks after exposure, and they will also resolve within 2 weeks after stopping the medication. That's why I remember it. Um, for the non-anaphylactic reactions, so that means we are talking about maybe type 3, type 4, it's usually occur after like 1 to 2 weeks after you start the drug, right? Not immediately, you know, and it stops 1 to 2 weeks after you stop the medication. That's when they resolve. If a patient reacts within 1 or 2 days of starting a new drug, it's not probably the causative agent, because if it's going to even be a type 1 urticarial lesion, it's not going to appear within 1 or 2 days. It's going to appear within like few minutes to hours, right? So if you see the patient developing rash within 1 or 2 days of starting a drug, don't think about drug as a cause of that eruption. So, and again, we need to know the pattern of eruptions. They are usually widespread, just like we said. They are like all over the place. They are symmetric and they are puritic. They are puritic, they are symmetric, and they are, so that means that symmetric means that they affect like both sides, equally, right? And they are puritic and they are widespread. So don't forget that they are puritic, they are symmetric, and it is widespread because it's a systemic thing. So it has to be widespread. This is not contact dermatitis. You are taking drug into your body, right? So it's going to be widespread, definitely. It's symmetrical and it's puritic. And most of them disappears within 1 or 2 weeks after you remove the drug, after you stop the drug. So the first thing you do when you identify that somebody has a drug eruption is to stop the drug first. You know, that's the first thing to do before you now start doing your symptomatic treatment. The patient is having pruritus, you want to give you antihistamine, you want to give you a topical steroid. You know, um, yeah, essentially that. So what are the complications that can happen from drug eruption? So they can have erythema. So erythema just means you're having like erythematous lesion affecting about 90% of the skin surface, right? So they can see some scaly erythematous region affecting about 90% of the cutaneous part of the body, the skin. That is erythema. They can have Dress syndrome. So these are stuff that they commonly test. Dress syndrome is known as drug reaction, the DR, drug reaction with eosinophilia and systemic symptoms. So that means that you have a drug administered. After 1 to 2 weeks, the person starts developing some systemic issues as some rash, and from blood work, you are seeing eosinophilia. That's what it means. So the individual is going to be having atypical lymphocytosis. They are going to be having eosinophilia. You check the platelet count, it's going to be low. They have thrombocytopenia. Then systemic symptoms, you know, systemic symptoms like look at all the systems from the lungs to the brain to the kidneys to the liver. But the number one that you must always remember for dress in terms of the organ that is affected is the liver. So you just see them having deranged liver enzymes. Usually it's characterized by elevation of the ALT. So the alanine transaminase level is usually elevated. It can affect the kidneys, and it can even range from acute, interstitial nephritis to acute tubular necrosis, and most of them they will be evidenced by elevation of the blood urea nitrogen levels. Right? You just think about an individual starting a medication now, then after some weeks, the person is having eosinophilia, having some rash, then subsequently having elevated, BUN. Think about DRESS syndrome. So liver marker elevated, blood urea creatinine level elevated. They can have interstitial pneumonitis, they can have pleurisy, they can have ARDS affecting the lungs, right? You know, so many organs affected at the same time, but commonly it affects the lungs, if it affects the kidneys, it affects the liver, it can affect the heart, and they can have left ventricular dysfunction. So this is about DRESS. So think about the onset of the drug that you have given a medication. After some weeks, you do your lab value, you are seeing eosinophilia, you are seeing thrombocytopenia, right? And evidence of end organ damage. That is DRESS syndrome. So DRESS syndrome is very common with some specific medications. And I am happy that these medications are also, the medications that trigger Steven-Johnson syndrome and TN. So it makes it very easy for us to learn everything together. And what are these medications? You cannot forget them. I think we have it down, but let me try to tell us some of them. The antibiotics, penicillin, sulfonamide, ampicillin, right? So they tell us that individual used trimethoprim, sulfamethoxazole, sulfamethoxazole, trimethoprim, which is our Septrin, which is an example of sulfonamide, penicillin, ampicillin, right? Or the person used anticonvulsant. So anticonvulsant like phenytoin, like carbamazepine, like lamotrigine, they are very important candidates. Anti-gout medication like allopurinol, right? We cannot forget that. Sometimes NSAIDs too can trigger this, right? NSAID can trigger it, steroid can trigger it, allopurinol, penicillin, anticonvulsant like phenytoin, carbamazepine, lamotrigine. They can trigger, DRESS reaction. They can also trigger Steven-Johnson syndrome and toxic epidermal necrolysis. And what is essentially happening here is just you having um, um, erythematous macles, erythematous purpuric macles, that can evolve to form vesicles and blisters that eventually slot off. Because what you are going to be having is eventual necrosis of the entire epidermis and it's going to shed out. That is Steven-Johnson syndrome and toxic epidermal necrosis. And we are going to talk about it shortly. So what about the drug reaction? Your exam finding and your history are also sufficient. So you can see that most of the diagnoses of the dermatology section, they are clinical, right? You just need to separate it from other things, the viral exanthema, right? Because you have said most of them have, this mobiliform pattern. So this could be measles, right? Rule out measles. Your graft versus host disease too can appear that way. Some of those autoimmune dermatosis, can also have similar presentation. So a skin biopsy, might be important, to help you with your diagnosis if you are not sure what you are working with. And of course, by the time you do your biopsy you are going to see evidence of eosinophilia, right? So how do you treat? Just like I've said, discontinue the offending agent, right? And you want to do symptomatic treatment. That is it. And what is the basic symptoms? You have said it. This individual is going to be having pruritus. There is severe pruritus. So give your antihistamine, to ameliorate the pruritus, and your topical steroids to relieve the pruritus. But if it's severe and your topical steroid is not working, your antihistamine is not working, give your systemic steroids, or you give your IV immunoglobulin to dampen the immune response. That is it. So just think about drug eruption as you discontinue the trigger, you giving symptomatic treatment, antihistamine and topical steroid. And if your topical steroids are not working, escalate to the use of systemic steroids and IV immunoglobulin. So moving on to erythema multiforme. So by the time we start talking about stuff like erythema multiforme, we are already moving towards the bullous lesions, right? The bullous lesion. So first thing I want to mention about erythema multiforme is that it is part of the type 4 hypersensitivity reactions. And one thing that is classic about erythema multiforme is that it has these targetoid lesions. You are going to see the targetoid lesions, which I'm going to show us shortly. Sorry about this. Sorry about this. I don't know why I cannot highlight. It is happening. It is happening. Um, okay, I sort that out later. System has decided to misbehave. So the classic targetoid lesions, the targetoid lesions, once you see targetoid lesion, think about erythema multiforme as a differential, right? So it is a type 4 hypersensitivity, cutaneous reaction with the targetoid lesions. It has many triggers, but the number one trigger we must always remember is what? Episimplex. Episimplex infection is the commonest cause of erythema multiforme. Bacteria can cause it like Mycoplasma pneumoniae. So if it's not from Episimplex, it's going to be from Mycoplasma pneumoniae, right? Some, sources have also said that some drugs can trigger it, phenytoin, antibiotics, yeah. But have Episimplex as the number one in your mind. Have Episimplex as the number one in your mind. And because of the fact that erythema multiforme can be recurrent, that is why you give antiviral agent like acyclovir, like valcyclovir, to treat recurrent of erythema multiforme, because we already know that the most common implicated organism is Episimplex. So give your acyclovir to eradicate the organism so that you can finally cure the recurrent erythema multiforme. So how does it appear? How does it start? I think I have like something I've scribbled right here. Uh, okay, I think I lost it. I have it somewhere. Oh my god, I think I lost it. Okay, but yeah, so we just have to know that most of the time they can start at just erythematous macles, right? They can just start as erythematous macles that can now evolve into forming the target lesions. They start from the extremities usually. They start from the extremities, usually the soles of the leg and the palms, and they ascend proximally to affect the other part of the body, right? So it will now start changing from the macles to the target lesions. And how do we describe the target lesions? I don't like this particular image, but I have some images for us, to show us what I'm talking about. So this is the classic lesion. This is a classic targeted lesion. And the way this lesion exists is that you are going to see an outer erythematous ring, right? An outer erythematous ring, a middle pale edematous layer. So there's a middle pale edematous layer, and there's an innermost layer of blister. But most of these blisters will rupture and they will form erosions. So this eroded area will now, appear dusky, right? So just remember those three, descriptions. So the outermost erythematous layer, the middle edematous pale layer, and the innermost dusky area. So this is, your target lesion for erythema multiforme. And, that's exactly what is being described here. A central dusky blister, right, surrounded by a pale edematous ring, right, with a very, very halo of erythema. We have said the same thing. We have said the same thing. So don't forget, they usually start from the palms, and the sole. They can affect the other part of the mucosa, like the lips, right? Don't forget. And the affectation of the mucosa helps us to categorize it into two forms: the erythema multiforme minor and the erythema multiforme major. So when it affects the mucosa like the lips, it becomes erythema multiforme major. When it is confined to the skin only, it is erythema multiforme minor. So it's going to affect the management. It's going to affect the management. So that is very important for us to know. So because of the fact that these lesions These target lesions can also occur in individuals with toxic epidermal necrolysis or Steven Johnson syndrome. You need to do some tests to separate it, right? And this is stuff like the Nikolsky sign. So by the time you apply pressure to these blisters areas, they don't rupture. The Nikolsky sign is negative in erythema multiforme, right? So erythema multiforme minor is uncomplicated and is localized to the skin. Don't forget, the erythema multiforme major involves the mucous membrane like that of the mouth, the genitals, right? The genitals, the mouth, and it is a distinct entity from Steven Johnson syndrome, and there's no risk of progression to toxic epidermal necrolysis, just like I've said. Wow, because both of them have like similar presentation, right? There's some degree of overlap, but Nikolsky sign is always negative in your erythema multiforme. That's number one. And most of the time, the trigger for your Steven Johnson syndrome or TEN is going to be use of drugs. It's very rare for drugs to trigger erythema multiforme. Most time, it is from infection like episymplex or from from mycoplasma pneumoniae. So, because of the fact that erythema multiforme usually, start from an infection, so you are going to get some systemic symptoms like fever, myalgia, arthralgia, headaches. Although this doesn't separate it from SGS or TN, because SGS or TN will also have this. They also have fever, they have arthralgia, they have headache, they have hypotension. They have system problems too. You know, so don't forget, EM, erythema multiforme, is usually triggered by HSV or mycoplasma. Very important stuff. Very, very important stuff. Erythema multiforme comes from infection like HSV or mycoplasma pneumoniae, while SGSTN are typically caused by drugs. But both of them are type 4 hypersensitivity reactions. So, how do you do your diagnosis? We have said it. You obtain your history, and you look at the lesions, right? And you can do some tests. You can elicit some signs, like the Nikolsky sign is going to be negative. So if you try to unroof the blisters, they are not going to unroof. It's not going to break, right? In erythema multiforme. So that means that the Nikolsky sign is negative in erythema multiforme. So how do you treat? So first of all, systemic corticosteroids have no role. You don't use systemic corticosteroids, and symptomatic treatment is all you do, right? Symptomatic treatment is all you do. So basically, what you just do is that depending on the, I think I have it here. So depending on the cause, you just want to, do away with the underlying trigger. If it's a drug, stop it. If it's an infection, try to treat it, right? And you know, treat the underlying cause, right? Withdraw offending agent, because sometimes you can see that the lesions can be, pruritic and painful, so you can give analgesics and your antihistamine to resolve some of those symptoms. And because some of them are like blisters that becomes eroded, so you can apply some skin dressings, right? But if it's the case of erythema multiforme major, you have to do more than all this. Aside treating the underlying cause, withdrawing the offending agent, applying your analgesics or your antihistamine and your skin dressing, you need to give fluid, you know, to correct the fluid imbalance and electrolytes, because erythema multiforme affect the mucosa surface. So there's a high risk of fluid loss. There's a very high risk of fluid loss. There's a very high risk of the person even limiting oral intake, so becoming dehydrated. So you have to give fluid, to correct the electrolyte derangement and the fluid deficit. Because of the numerous, blisters that can happen, there's a high chance of secondary bacterial infection. So you don't give antibiotics until you are seeing signs of infection. That's when you give your antibiotics, right? You place the person on liquid diet, and if it's recurrent, you give your acyclovir. I think this is clear. So we usually treat the erythema multiforme major as born. So that's why we give fluids, we apply our dressing, we correct electrolyte changes, give analgesics, and if there's a need for antibiotic cover, you give antibiotics to treat any signs of infection. So, that's that about erythema multiforme. Most of the management is supportive, right? So, a differential diagnosis should always include SGS and TN if a Nikolsky sign is present. So, if a Nikolsky sign is present in a young child, think about, and there's fever, there's discoloration of the skin, but there's no affectation of mucosa. There's just perioral crusting. There could be perioral crusting, but the mucosa of the mouth itself is not affected. Think about staphylococcal scalded skin syndrome. But if there is affectation of the mucosa proper, right, and the individual is having skin necrosis with positive Nikolsky sign, think about your SGS, think about your toxic epidermal necrolysis. So, moving on to SGS and toxic epidermal necrolysis, we have said it that these individuals are type 4 hypersensitivity reaction, just like erythema multiforme, and they constitute two different spectrum of life-threatening exfoliative musculocutaneous disease, right? So they are usually caused by a drug-induced immunologic reaction. So most of the time they are secondary to drug use. So we usually have a prodromal phase, that happens 1 or 3 weeks after you have started the medication. And how is this patient going to present? So we have it here. Number one, the prodromal phase usually occur within 1 to 3 weeks after you have started the medication. So it's like we are talking about the drug eruption, right? And they usually have high fever first. You see the high fever greater than 39 degrees Celsius. They are going to have some systemic non-constitutional features like malaise, right? Sore throat. They can have myalgia, arthralgia, just like in people with erythema multiforme. Then 1 to 3 days after this constitutional symptoms of the high fever, the malaise, the arthralgia, the mucocutaneous lesions will now start appearing. So they usually have painful erythematous or purpuric marco. So purpura is like bleeding into the skin, like white, like like big bleeds, more than petechial rash, you know, into the skin. So you have this painful erythematous purpuric marcos in the skin. Then they will start evolving. Some of them can evolve into targeted lesions. So that's why we said that it kind of overlaps with erythema multiforme, kind of, right? So they can appear targetoid, in which you are going to be seeing the outer erythematous lesion, the middle pale edematous layer, and the innermost dusky layer that contains the bullae that sometimes rupture, right? And sometimes you might see some bullous vesicular lesions. And of course, once you exert pressure on the bullae, they are going to rupture, which is in keeping with the positive Nikolsky sign, right? Then later you notice that the entire full thickness of the epidermis is going to start undergoing necrosis, and they will be shedding out. So there's going to be full thickness necrosis of the epidermis with sloughing resembling burns. So that's why the treatment of erythema multiforme major and the treatment of your SGS TEN is in keeping with burn injury, right? Don't forget, the mucosal surface is always involved in SGS TEN compared to some other conditions. For example, erythema multiforme minor doesn't have involvement of the mucosa. Erythema multiforme major has mucosa. SGSTN also has mucosa. They are always involved in SGSTN. Don't forget that. The mucosa is always involved. What we just differentiate SGSTN from erythema multiforme is what? The positive Nikolsky sign in SGSTN, which is negative in erythema multiforme, regardless of if it's erythema multiforme major or minor. They always have a negative Nikolsky sign. Don't forget that. I have emphasized it. Please, we should take note of it. People with SGSTN, because of the widespread sloughing off of the skin, so they can have a very high chance of fluid loss, and they can go into hypovolemic shock, as as fast as possible, and they can also have septic shock because the immunologic barrier is gone. There's more like a very good potent source for microbes to thrive. There's avascular skin, there is lots of immunologic barrier. Mycobacteria can easily translocate, and the individual can get um, septic shock. So that's that about um, SGS TN. So how you just differentiate between SGS and TN is that SGS occur when you have the epidermal separation involving less than 10% of the body surface area, right? When it's just involving like less than 10% of the body surface area, that's when it's going to be SGS. But when it's more than 30%, when it's more than 30%, that is when it becomes TN. TN is better than SGS. So most of the time when it's affecting the back, you already know that it's going to be more than 30%. It's affecting the back down to the extremities. Forget about it, it's going to be TN. So mucosal involvement occurs in about 90% of the cases. So it's very high yield. And Nikolsky sign is positive, and you're going to get history of use of certain drugs like Septrin, trimethoprim, sulfamethoxazole. So what do you see? You just see this. You can see this in now. This back is affected, extending down to the extremities. So this definitely TN. You can see the blisters, that are ruptured and the skin shedding. And the examination is going to review mucosal erosion with widespread erythematous purpuric macules, right? We can see like some of those macules, the purpuric macules, the bleeding, right? And um, sometimes you can have atypical targeted lesion. We don't have the targeted lesions here, but sometimes you can have atypical targeted lesions. So don't get confused when you see targeted lesions in people with SGS or TA, right? So if you try to apply pressure, you see that some of those skin will start shedding, which is your positive um, Nikolsky sign, right? Separation of superficial skin layers with slight rubbing, you know, and eventual detachment of the epidermis. So the mucous membrane is always affected. They can have conjunctivitis, they can have problem with the mouth, genital erosion, and hemorrhage at the end of the day. The drugs, we have mentioned some of the drugs initially, the antibiotics. So sulfonamide, penicillins, um, fluoroquinolones, cephalosporins. So the antibiotics. Think about the antibiotics. The sulfonamide, the penicillin, the fluoroquinolones, the cephalosporin. Think about the anti-seizure medications. We have talked about that too. Just like in Durable-Dress syndrome, phenytoin, carbamazepine, lamotrigine, right? Think about your NSAID and your steroids. Steroids and NSAID. So, you know, they would give you one of these drugs, but most commonly they choose the sulfonamide. They can also take the anti-seizure medication. So, have that at the back of your mind. Don't forget that this is a form of drug eruption. So, if you do your biopsy, you are going to see full thickness necrosis, right, of the epidermis. So there's going to be full thickness necrosis of the epidermis with eosinophilic infiltration. Don't forget, eosinophilic infiltration is classic for drug eruption. So biopsy is going to reveal full thickness epidermal necrosis with eosinophilic infiltration. So your differential diagnosis would be like stuff like staphylococcus, cardiac skin syndrome, right? In young children less than 6 years, but most of the time it doesn't involve the mucosa, right? So that's one thing that separates SSS from TN, even though both of them will have positive Nikolsky sign, but this doesn't usually involve the mucosa and it's very, very common in young children less than 6 years. you know, this presentation is very similar to people with the rash, from graft versus host reaction, or people exposed to radiation and burn injury. So, um, there's a key fact here that further emphasize, that we should not confuse SGS and TN with Staphylococcus syndrome, because SSS is very common in children less than 6 years, and they don't have the targeted lesions that we can get in SGS TN, right? And SGSTN is commonly seen in adults and is caused by a drug reaction. So that's very important for us to remember. So what do you do? Because they have a very high risk of dying, there's a very high risk of mortality because this is epidermal necrosis. You are losing fluid, you are losing electrolytes. There's a high risk for infection because of the breakage in the, immunologic barrier. So you have to act fast, provide supportive treatment as soon as possible. And that starts with making an early diagnosis. You know, make your early diagnosis, obtain the history of use of medication, look at the skin lesions, how they appear, exact your Nikoski sign, discontinue whatever medications that they are taking because it's very critical to ensuring that they survive. And because they have complications like individual bonds, the fluid and electrolyte deficit, you have to quickly ensure you restore a thermoregulatory balance, right? By applying your wound dressing, to cover this skin and correct your fluid and electrolyte derangement, right? By giving fluid, by correcting the electrolyte, then placing on antibiotics, right? In case there's any evidence of secondary infections, right? So we should not bother about this because the data is confusing. The data about use of steroids, cyclosporine, or IVG is not yet confirmed. So we should not worry about that. So just do your supportive treatment, basically wound dressing, your analgesics, right, for the pain, you know, um, your fluid and electrolyte correction, your antibiotic in case there's secondary infection, right? So moving on to erythema nodosum. So erythema nodosum is one of those classic lesions that we must be able to identify, you know, why I'm going for our exam. Very, very important stuff. And the the acronym nodosum can also help us remember, um, you know, the etiology of erythema nodosum. The NO is talking about no, which is idiopathic. You don't know the cause. In 60% of the case, you don't know the cause of erythema nodosum. The D is talking about the drugs, right? The drugs, the sulfur drugs. So I use your acronym SOP. So the sulfur for the hairs, the O for the oral contraceptive, the A for the antibiotics, and the P for penicillin. So iodide is also part of it. Iodide is part of it. Iodide. Yeah. So then for the O, we talk about the oral contraceptive, just re-emphasizing that. The S for sarcoidosis. So you cannot forget sarcoidosis. When it comes to erythema nodosum, that is dangerous. You know, then the U for ulcerative colitis and Crohn's disease. So IBD generally, IBD can cause erythema nodosum. Then the M for the microbiological infections, right? Your tuberculosis. Think about the chronic infections. Chronic infections majorly. Your Mycobacterium tuberculosis, your Mycobacterium leprae, histoplasmosis, you know, um, and some other ones, the Yersinia, Coccidium, the Coccidioides, Coccidioides. Wow, why am I finding difficult to pronounce? Coccidioidomycosis. I think that's okay. Coccidioides imitis, yeah. So, you know, your strep, tuberculosis, Yersinia, all of them can cause erythema nodosum. So I think I have another code that includes all these infection, and that is stylish. That is stylish. S for cryptococcus. So you cannot forget cryptococcus. You know, I said cryptococcus. Streptococcus. Sorry about that. Sorry about that. Streptococcus for the S, the T for the tuberculosis, the Y for the Yersinia, the L for the leprosy, the I for, you can think about iodine again. Think about iodine again. The S again for the streptococcus, then the H for the histoplasmosis. So I was just able to look for something to just, take, some of them. So what is erythema nodosum itself? So erythema nodosum is a paniculitis. Very important stuff because sometimes you might be asked to make the diagnosis, and the next thing is, what is peculiar about this lesion? That is going to be in the option. This is a paniculitis. This is due to dermal vessel extravasation. This is due to immune complex deposition at the dermo-epidermal junction. Series of things. But what you are looking out for is what? A paniculitis. And the word paniculus is just subcutaneous tissue, right? Inflammation of the subcutaneous adipose tissue is the cause of erythema nodosum. Very important stuff. It is an inflammatory process of the subcutaneous tissue, and it's very painful because of that. So it can be triggered by infection, just like we have said in our stylish, strep, the TB, the Y for the Yersinia, then the C for the coccidioidosis, and the Yersinia and the tuberculosis. Then drugs can also trigger it. Drugs, and we have said soap, sulfonamide, OCPs, antibiotics like penicillin, right? And some of those chronic inflammatory disease and the chronic infectious disease, sarcoidosis, Crohn's disease, ulcerative colitis, and Behçet's disease. All of them can cause erythema nodosum. So don't forget sarcoidosis, Crohn's, IBD, and your Behçet's disease, right? So you see somebody having oral ulcers, genital ulcers, erythema nodosum, uveitis. You can think of your Behçet's disease. Very important stuff. So how do they look like? You are going to be seeing painful. Of course, this is a paniculitis. Painful erythematous nodules. That is the word. It is usually nodular most of the time. It is nodular. So you are going to be seeing stuff that look like this, like pop-off. Painful erythematous nodules that appears in the anterior shin. So that's a classic location. Most of the time, you see it in the anterior part of the shin. So an individual having painful erythematous nodule appearing in the anterior shin, that when you touch it, it is very tender. That changes color sometimes to brown or purple. That's the erythema nodosum. That is the erythema nodosum. So sometimes the individual can present with fever or joint pain. Of course, this thing comes from systemic cause most of the time, maybe chronic inflammatory disease or chronic infectious disease. So we are going to have some other systemic findings like fever or joint pain. So you can see the erythematous nodules and plaques here in the anterior part of the shin, right? So it's also important for us to remember that this is also part of the the first positive cause of the cause of false positive VDRL test. So aside SLE, aside use of medication like chlorpromazine, procainamide and the likes, SLE, leprosy, hepatitis infection, Epstein-Barr infection, erythema nodosum too, have usually people with erythema nodosum too have a false positive venereal disease research lab result. So have that at the back of your mind. Don't rush to go and pick syphilis. If you see positive VDRL test, it could be erythema nodosum that you are looking at. So usually the diagnosis clinical, the exam findings and the history, they are sufficient. You can obtain a biopsy to establish your diagnosis. And what are we looking out for? Inflammation of the fat tissue, paniculitis. You can do your laboratory workup to investigate for the cause. We already have our stylish S for the streptococcal. So we want to evaluate the anti-streptococcal titer, the ASO titer, which is going to be elevated. Your PPD test to rule out tuberculosis in people that are high risk. You can do your chest X-ray to rule out sarcoidosis, in which you are going to be seeing evidence of bilateral mediastinal hilar lymphadenopathy. So once you are seeing mediastinal hilar lymphadenopathy, reticular opacities in the lungs, think about sarcoidosis. And of course, rule out IBD, inflammatory bowel disease, colonoscopy, because Crohn's disease, ulcerative colitis are common causes of erythema nodosum. So how do you treat? Don't forget, iodine can be a cause. Iodine can also be a treatment. Potassium iodide can also be a treatment. So I was supposed to mention that initially. So you have to investigate and treat the underlying cause first. Then you can also, do some symptomatic treatment. You apply cold compresses to the areas where the lesions are. You exercise bed rest, and you give NSAID for the pain, right? You apply cold compress to the area to limit the inflammation, to limit the pain. You tell them you have to ensure that they are resting, give them NSAID, and if it still persists, you can apply potassium iodide, in persistent cases, potassium iodide. So moving on to the bullous pemphigoid and the pemphigoid vulgaris. So these are autoimmune blistering dermatosis. So they cause blisters. So once you see blisters, you know, in an elderly person, think about your bullous pemphigoid, think about your pemphigoid vulgaris. Blisters in an adult, more than 40 to 60 or like 60 above, think about your bullous pemphigoid, think about your pemphigoid vulgaris. So we need to know the difference between them. First of all, these two conditions are type 2 hypersensitivity reactions, right? They are antibody mediated. We have some antibodies in the body that is, destroying the structures within the epidermis, right? That is what is responsible for all this. And what is the difference between them? Because both of them, they are blistering lesions, they form blisters. The blisters for bullous pemphigoid is located down at the basement membrane. It's here. This is the epidermis. This is the dermis. This is the basement membrane. So this is where the blisters are formed for um for bullous pemphigoid. So here, this is where the fluid is going to be accumulating, because this is where the problem is. Then for pemphigoid vulgaris, it is intraepidermal. So the fluid accumulates in between the dermis, in between the epidermis rather, in between the layers of the epidermis, particularly like between the stratum spinosum and above the stratum basale. So this is the stratum basale, this is stratum spinosum. So that's where you have the fluid accumulating and they form the blisters. Now, what are the antibodies involved? The antibodies involved in the bullous are antibodies against the hemidesmosomes, right? And these antibodies are targeting the bullous pemphigoid antigen 1 and 2. So you have these antigens, at the junction between the stratum basale and the dermis, right? Just at the basement membrane separating both of them. So that's where you have those antigens, and you have this antibody, attacking that area, destroying, the basement membrane. So that's that about the autoantibodies for bullous pemphigoid. Why for pemphigoid vulgaris, you have antibodies against the desmosomes, the desmoglein 1 and 3. And what they do is that it helps to adhere the stratum spinosum, the granulosum together, particularly attaching your stratum spinosum to your stratum basale. So if those guys are damaged now, you have space in between your stratum spinosum and stratum basale for fluid to accumulate. So they are attacking the desmoglein 1 and 3. Why the bullous pemphigoid is down, attacking the hemidesmosomes. This one is attacking the desmosomes, desmoglein 1 and 3. Don't forget that. Don't forget that. Now, one thing I want to mention is that bullous is very common in elderly, more than 60 years, while pemphigoid is usually common in people between 40 to 60 years. That's number one. And number 2 point is that pemphigoid is much more severe than bullous, because pemphigoid will affect the mucosal surface, unlike bullous that doesn't usually affect the mucosal surface like the mouth or the genitals. And pemphigoid usually ruptures. And if the blisters ruptures, it's bad, because there's a high chance of infection coming in. It just exposes the skin, right? So pemphigoid is bad compared to bullous pemphigoid, because the bullous pemphigoid, the blisters are tense, so they are stable, they rarely rupture, right? They rarely rupture, and sometimes you can have some eczematous rash or urticarial rash that precedes the development of the tense bullae. But you have to take home the fact that the bullae in bullous pemphigus is tense, while the bullae in pemphigus vulgaris is flaccid, so they can easily rupture, right? So you see erosions than intact blisters in pemphigus vulgaris because you don't have any keratinocyte to help you, you know, reinforce those epidermal interconnections. There is no desmosome connection to reinforce the intraepidermal connection, so they can easily rupture. But for the bullous, the fluid accumulates here, and this junction here is kind of very solid. It doesn't allow for the blisters to rupture. If the fluid accumulates here, it can be cushioned by the force downwards here, and it doesn't readily rupture. But if it's here, it can the keratinocytes are not strong enough to withstand the pressure, so it just be rupturing, bang, 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 bang. So pemphigus vulgaris form flaccid bullae that easily ruptures, while the bullous pemphigus form tense bullae. So because of that, it makes sense for us to know that the Nikolsky sign is positive in pemphigus vulgaris, right? Because they can easily rupture, while the Nikolsky sign is negative in bullous pemphigus. We have talked about the fact that mucosal involvement is very rare in bullous pemphigus. Mucosal involvement is very common in pemphigus vulgaris, right? Bullous pemphigus is the problem of elderly people more than 60 years. So once you look at the age in the question, guys, once you look at age in the question and it is between 40 to 60 or more than 60, then you can consider these people, this bullous pemphigus or pemphigus vulgaris. But if it's less than 40, please don't pick any one of them. So people that have pemphigus vulgaris are usually between the age of 40 to 60, while people that have the bullous pemphigus are usually more than 60 years. The trigger for the bullous pemphigus is usually idiopathic. We don't know the cause most of the time. Why that of the pemphigus vulgaris too can be idiopathic, but sometimes it can be provoked by drugs. Just remember the pemphigus, so the penicillin, the penicillamine, phenobarb, and the ACE inhibitors. So ACE inhibitors, which can also provoke lichen planus and the likes, is also part of the agent that can provoke pemphigus vulgaris. So ACE inhibitors, penicillamine, phenobarb, penicillin. So because of the fact that we already said that bullous is mild compared to pemphigus vulgaris, so the mortality is rare because it doesn't affect the mucosal surface and it does not blister. It does not rupture, rather. It doesn't rupture to form erosions. But this one has a very high chance of mortality from fluid loss, from electrolyte derangement, from infection, right? Because of the break in the blisters. So how do you make your diagnosis? Of course, the physical examination of the lesions can give you an idea, right? The tense bullae on the trunk will make you know that this is likely to be bullous, while the flaccid unroofed bullae and erosion, within the extremities and the mucous membrane, will make you have an idea that this is likely to be pemphigus vulgaris. So once you are seeing tense bullae, think about bullous pemphigus. But once you are seeing flaccid bullae with erosions, think about pemphigus vulgaris. But the most accurate test is to do your skin biopsy with your direct immunofluorescence enzyme link assay. So you have to do like a fluorescence analysis after you do your biopsy, right? And what are you looking out for? What you are looking out for, I don't know if you are still okay. Yeah, so when you do your immunofluorescence, you are trying to look at the way the autoantibodies are arranged, right? So in the bullous pemphigus, we already know that the problem is down between the epidermal dermal junction here at the mesenchymal membrane. So that's where the separation is happening. This is the epidermis being carried up from the underlying dermis. So this is where the problem is happening, right? So you are going to be having deposition of the autoantibodies here. So you are going to be having a linear pattern of IgG complement protein C3 deposit in a linear pattern within this basement membrane, within the dermal epidermal junction, right? That's what you are going to be having for bullous pemphigoid. But for pemphigoid vulgaris, it is not going to be linear because this is happening here, and we can see that they are kind of interspersed. So you are going to be having a reticular deposition of IgG antibodies. By the time you do your immunofluorescence, it's not going to be linear like in bullous. Bullous is going to be linear, while pemphigoid vulgaris is going to be reticular, right? And in pemphigoid vulgaris, because of the fact that it does not affect the distal part, so these basal layers of the epidermis is going to be intact, unlike this one that is already taken off. So this is going to be intact, and they have this tomb of cells, like roll of tomb, you know, roll of tomb appearance. So it's going to look like a graveyard, right? Roll of tomb appearance because of the intact nature of the stratum basale in pemphigoid vulgaris. So once you see roll of tomb with a reticular pattern of IgG deposits, think about your pemphigoid vulgaris. Once you are just seeing linear deposit of IgG C3, think about your bullous pemphigoid. So just if you can't remember it finally, just calm down in your exam and look at the mental picture. Which one affects down structure? That is your bullous pemphigoid. So that means that you won't see roll of tomb because your basal membrane, your basal layer, your stratum basale will be elevated. While your pemphigoid vulgaris that affects the proximal structure. So that means that you are going to have intact basal layer, which is going to appear like a roll of tomb, right? Just like we have here. And you are going to be having your interspersed deposition of your autoantibodies, destroying the desmoglein attachment between the intraepidermal cells here. So they are going to have a reticular patterning on your immunofluorescence, but here is going to be linear patterning. So, what do you do to treat? Both of them, you have to give them high potency steroids, right? But because of the fact that pemphigoid vulgaris is more fatal, you have to add immunomodulatory therapy. That's where I see it. I do for both of them, but for your pemphigoid vulgaris, add immunomodulatory therapy like your azathioprine, like your rituximab. But that's that about pemphigoid vulgaris. Why for your bullous pemphigoid, you can start with your topical high potency corticosteroids. Then if doesn't work, you can try your systemic corticosteroid and also doxycycline. Doxycycline has also been shown to be effective in treating people with bullous pemphigoid. So just to look at the short note here, we compare and contrast the layers of the epidermis in normal skin with blistering dermatosis, right? Pemphigoid vulgaris involve disruption of the desmosomes and shows separation of the stratum spinosum from the stratum basale, causing the roll of tomb appearance. Bullous pemphigoid involve separation of the epidermis from the dermis due to destruction of the hemidesmosomes. So, a 20-year-old black man presented to the physician for a new onset painful rash. She noticed the erythematous nodules on the lower legs 3 days ago. She has an history of uveitis. So what's the best method to identify the underlying cause of the rash? So I know we already know that this is likely to be SAC, right? Because of the uveitis, it could, because of the uveitis. So with the erythema nodosum. So what's the best next step you want to do to you have to do your chest imaging, right? To just like we have here, you have to do your chest X-ray to look for evidence of hilar lymphadenopathy and the reticular networks. So chest imaging is the next thing. So moving on to the next lesion, and that is nummular eczema. So this is very straightforward. So this is just more like a chronic relapsing and remitting. So it keeps going, keeps coming, puritic, coin-shaped, scaly plaque. So the point here is the fact that it is dry because this is enzymatous. So they are dry, right? They are scaly, right? And they are puritic. So those are the three take-home points I want us to always remember for the nummular eczema. So the reason why we are not calling it nummular is because it has all these three things we have said: the dry, the scaly, plaques, which is puritic, right? The dryness, the scaliness, and the puritic nature, and is now having a characteristic shape, which is what is coin shaped. So that's why I call it nummular eczema. So a dry, puritic, scaly lesions, plaques that is coin shaped, usually within the extremities, is nummular eczema. So the pathogenesis is not too clear, but it's believed to be due to destruction of the skin epidermal lipid barrier, so causing loss of fluid, loss of oil, sebum, the skin lipids, making the skin appear dry and not and rough, because it's not going to be supple, it's going to be dry and rough. So don't forget about the fact that there's dryness, xerosis, and there's decreased skin lipids. So there's a damage to the skin lipid barrier, causing reduction in the skin lipids and dryness of the skin. It's clinical. You don't need to do any biopsy. So how do you treat? Because I already know that there's xerosis here. You have to apply your emollient, definitely, and you have to avoid harsh soaps, to prevent further dryness of skin, and use your topical steroids, just like normal atopic dermatitis. Put your emollient, apply your topical steroids, right? So they are like 5 centimeter large, cone shaped, well demarcated erythematous, dry, scaly plaques, right? That is nummular eczema. So I'm sure we'll be able to figure this out by the time we see it in our exam. Apply your emollient, apply your topical steroids. So the next is the pyodermal gangrenosum. Very easy stuff, very easy to pick, and this usually start like small papules or pustules. They usually we are going to get the history that the lesion start as a small papule or small pupule, but small papules or pustules rather. Sorry, excuse me, small pustules or papule that rapidly progressed and become enlarged with eventual ulceration. And when they form that ulcer, right, you are going to see that the margin of the ulcer is going to be purplish in color, and it's going to have a purulent base. You can see this pus here within the floor, the base of the ulcer. We can see the margin having a purple coloration, and we can get the evolution of the lesion in the history, that it started at small purple, which is painful, which is which is small purple or pustule, that now evolve into an ulcer that is painful. That's what I want to say. The ulcer is painful with purulent base and a purplish margin. Now, it can be due to trauma, but sometimes we might not get history of trauma. That's number one point. The common cause are stuff like inflammatory bowel disease, right? Inflammatory bowel disease, rheumatoid arthritis, malignancy, especially the blood malignancy like acute myeloid leukemia, hairy cell leukemia. One of those three is going to be there. If trauma is not there, you are going to see rheumatoid arthritis, inflammatory bowel disease, or malignancy. It's very common in women, and it's very common in people within the age of 40 to 60 years, right? Yeah, 40 to 60 years. So it demonstrates pathogy. So this means that you are going to have new lesions, new ulcers developing in areas of trauma. So if you just apply it, so you just put like inflict small trauma within the areas of intact skin, you see that these ulcers are going to be developing at that point. So that's why in managing this pyodermal gangrenosum, you don't do your debridement. You must not pick debridement in your option. You must not. So pyo means pus, purulent base, derma, the skin, gangrenosum, looking as if there's gangrene, within that area. So don't forget the evolution of the ulcer. Start small, becomes big, painful, purulent base, violaceous or purple colored margins, right? Common in women more than 40 to 60 years. History of rheumatoid arthritis, inflammatory bowel disease, any blood malignancy, right? Don't debride. Don't debride. So treatment involves giving your local or your systemic corticosteroids. You can also use cyclosporine. So you can give your steroid or you can use cyclosporine, right? In making your diagnosis, you might need to rule out infection. To rule out infection, this would be like Borrelia or something. You know, it could be due to Pseudomonas. You know, rule out cutaneous or cancers, especially the squamous cell carcinomas of the skin. Rule out venous ulcers because they can present this way. And sometimes you might need to do a biopsy to confirm your diagnosis. And what you are going to be looking out for is mixed cellular infiltrates. So, but those cellular infiltrates are going to have a neutrophilic predominance. This is a neutrophilic problem. It is the neutrophils that are much more involved. So, just like we have here a neutrophilic dermatosis. So, that's one point we must take home as well. When you do your biopsy, you're going to see mixed cellular infiltrate with predominance of neutrophils, right? You biopsy the margin. You biopsy the margin. Please don't biopsy inside the ulcer. Biopsy the margin. So that's that about pyodermal gangrenosome.